Good evening. I'm psychiatrist Jay Fulver, live from Fort Wayne, Indiana. Welcome to Matters of the Mind. Now in its 27th year, Matters of the Mind is a live call-in program where you have the chance to choose the topic for discussion. So if you have any questions concerning mental health issues, give me a call here in the Fort Wayne area by dialing 969-2720, or if you're calling anyplace else coast to coast, you may dial toll-free at 866-969-2720. Now on a fairly regular basis, we are broadcasting live every Monday night from our spectacular PBS Fort Wayne studios, which lie in the shadows of the Purdue Fort Wayne campus. And if you'd like to contact me with an email question that I can answer on the air, you may write me via the internet at Matters of the Mind, all one word, at WFWA.org. That's Matters of the Mind at WFWA.org. And I'll start tonight's program with an email I recently received. It reads, Dear Dr. Fulver, how would a person do on Prozac if that person does not have depression? Prozac came out in 1987. Its generic chemical name is fluoxetine. When it came out, it was thought to be a miracle medication. And the reason it was thought to be a miracle medication is because it was the first antidepressant that was actually highly tolerable. It didn't work any better than the prior antidepressants. You know, the prior antidepressants all affected serotonin, norepinephrine, somewhat dopamine. Prozac or fluoxetine was very, very specific on increasing serotonin. And it was so specific on increasing serotonin, it did not cause dry mouth, weight gain, lightheadedness, cardiovascular problems like the other medications could. So it was a very tolerable medication, and people could take it day by day. And if they missed a dosage, they could actually make up for it because fluoxetine or Prozac would stay in your system for several days. So way back in the late 1980s, other people were asking the same question as are you. And they were asking, why don't we just have everybody take Prozac? Because it seems to help so many people. And there was actually a psychologist out in Washington State proposing seriously that they put fluoxetine or Prozac in the water supply. Well, here's what happened when they actually studied fluoxetine or Prozac in people who didn't have depression. And then they studied it in a related group with people with placebo, and then they crisscrossed them. What they found with the fluoxetine people, the Prozac people who didn't have depression, was that they would have an emotional dulling effect. It wasn't necessarily a horrible effect, but they just felt emotionally numb. They felt not good, they did not bad, they just kind of felt blah. And what Prozac or fluoxetine will do, it increases serotonin and it gives you this blissful calming effect, and it's kind of an emotional numbing. So if you're having difficulty with unnatural crying or extreme anxiety, fluoxetine or Prozac can dampen that down. And you gotta find just the right amount for it to work, but it'll dampen down excessive emotions. Now, what if you have what we'd call normal emotions, where you don't have anxiety to an abnormal degree, you don't have depression for that matter? Well, it'll probably make you feel kind of blah. And that's what it did for a lot of people. And many people who took Prozac, if they didn't have depression, felt some sexual side effects. They had some diarrhea, gastrointestinal problems, some headache. We now know that as serotonin toxicity. In other words, they're just getting too much serotonin in their system. So if you don't need fluoxetine, it's kind of like putting on somebody else's eyeglasses. You put on somebody else's eyeglasses and you'll just find that your vision's is actually worse, if anything. If you take Prozac and you're not depressed or you don't have that much anxiety, you'll just feel a little bit of emotional dulling effect. And you might be able to put up with stuff a little bit better to some degree, but most people wouldn't like how they felt if they took Prozac, if they didn't have what we'd consider to be pathological depression or anxiety. Thanks for your call. Let's go to our first caller for tonight. Hello, Jan. Welcome to Matters of the Mind. Jan, you heard me say normal. So what is normal? How do you know if a treatment's working or not? Well, normal basically, Jan, is where you don't have significant functional impairment. To have a psychiatric condition, by definition, you have to have impairment with social work or school functioning. You have to have a hard time getting along in life. So basically normal is where you can pursue happiness, you can live relatively independently and be self-sufficient, and you can get along with other people, and you can have interpersonal relationships that are there to a meaningful degree. So normalcy basically is where you can be all you can be, and you're not having anything from an emotional standpoint impair your ability to getting there. So people will have mood and anxiety disturbances. They'll have difficulty with thinking due to mental health disturbances. If we can treat those mental health disturbances, the idea would be that you'd be able to have those meaningful relationships. You'd be able to pursue a job or school opportunities as you would intend to do so. And you'd be able to stay active physically within your within your level of physical abilities based on your age and your overall physical health. So you're able to be all you can be, to use an old term from the United States Army. They always talked about being all you can be. Well, that's what it's all about. Normalcy from a mental health standpoint means that you can be all you can be, and you don't have that degree of functional impairment. How do you know your treatment's working? I always suggest to people that they give me the main treatment goals that they have in mind right off the bat. What kind of treatment goals do you have? What would you hope any treatment from a mental health standpoint would do for you? And have the patient identify what their main goals are. And you, as a clinician, you're often surprised because you're thinking, I thought they might have this goal or that goal based on their symptoms, but many people will have different goals than a clinician might believe. So I think it's imperative that the clinician ask the patient what goals he or she is pursuing, and then you follow those goals over the course of time. And the goals might be something as simple as getting better night's sleep, having more energy during the day, having more motivation, having more enjoyment with the grandchildren. It can go in a wide range of areas and then kind of track how those goals are doing. And the patient will often identify what those goals should be. So successful treatment should be where somebody is feeling like they can still experience happiness, anger, sadness, apathy, irritability. They can still experience the wide range of emotions. That's all good. Otherwise, you're going to be an emotional robot. You don't want that. But you should still feel emotions based on life circumstances. And you should especially, on one hand, be able to enjoy your sensory environment around you. You should be able to enjoy things that are currently in your presence, but you should also look forward to enjoying things in the future. Enjoying things now is called consummatory enjoyment. Enjoying things in the future is called anticipatory enjoyment. You should have both of those aspects where you can look forward to the future and still have hope. And even though things aren't going so well for you now in different areas, you realize that as you wait it out over the next few weeks or months for that matter, things will often change. And typically, for most people, things can change for the better, and you have to maintain that degree of optimism. Thanks for your call. Let's go to our next caller. Hello, Catherine. Welcome to Matters of the Mind. Catherine, you want to know, would hypnosis help someone with communication, would help with communication with someone who has autism? So you're asking, I believe, Catherine, if you have autism, would hypnosis help your ability to communicate? And I'd say probably not. Hypnosis, number one, you have to be extremely suggestible and trusting with the clinician for them to be able to hypnotize you. And the whole idea would be for you to be able to do self-hypnosis so you can practice over the course of time. So hypnosis is very good for anxiety. Hypnosis can be very relaxing and give you a calming effect in social situations. But with autism, basically autism is where the right front part of the brain is underactive to a degree where you don't have as many mirror neurons as you really should have. Mirror neurons basically are neurons that allow you to mirror the behaviors and the emotions of the people with whom you're communicating. So we will do this unconsciously. As we're talking to somebody, we relate to them by sometimes mirroring their mannerisms. It might be hand gestures. We might even take on the inflection of their voice, any accent they might have to a mild degree. We might take that on. And that's a means of connecting with somebody else. People with autism have a difficult time doing that. So it's not an anxiety condition per se, and I don't think hypnosis would really help with that. Thanks for calling. Let's go to our next caller. Or let's go to our next email for that matter. Our next email would read, here it is, Dear Dr. Fulver, how do you choose one medication over another, and what are the criteria that you use? When we choose medications, number one, we want to get a proper diagnosis. So if you have, let's say, chest pain, if you have chest pain, the first thing you need to sort out is what's causing the chest pain. Is it a heart attack? Is it bronchial pneumonia? Is it bronchitis? Is it asthma? Is it gastroesophageal reflux? What's causing the chest pain? So you're going to have different treatments based on the nature of the condition causing the symptoms. If somebody has, let's say, depression, we need to sort out what's causing that depression itself. Is it an emotional problem? We don't want to be too quick to jump at saying, well, it's because your life circumstances, it's this or this or this. I almost didn't go into psychiatry because I found that when I was a medical student back in the 1980s, I just found that a lot of psychiatrists were attributing symptoms to specific things happening in people's lives. And stuff happens in everybody's life. You can always identify certain things. So I always was one to want to look at the underlying problems on why people might have certain symptoms. So depression, for instance, somebody comes in and they say they have depression. You have to identify what symptoms they're experiencing. Are they having difficulty with fatigue, poor concentration, low motivation? Those kind of symptoms can be related to so many different things. Low thyroid, diabetes, you can have sleep apnea where you're not getting enough airflow at nighttime and you're snoring. You can have difficulty with all sorts of different endocrine problems and have difficulty with low motivation and poor concentration. You know, if you have poor concentration, that can be from attention deficit disorder. I saw a lady earlier this morning who had attention deficit disorder who also had trouble with motivation and get up and go. And she said she didn't feel depressed, but her clinicians who she had seen in the past were always telling her she must be depressed because she has low motivation and poor concentration. I believe that she was having trouble with motivation and being able to get things done because she had ADD symptoms. So you treat the ADD, those underlying symptoms that we might think of as depression might be mitigated. So I think it's important that we try to look at the underlying conditions that are there. You know, low iron. Women who are heavily menstruating or people who are vegetarians sometimes will have low iron, and low iron can contribute to feeling blah and feeling kind of down the dump. So number one, it's important that we identify what the underlying problem is and treat that particular condition. Is it bipolar depression, for instance, where they're intermittently having highs for several days and then they crash into lows? You're going to treat those people with a mood stabilizer. Is it depression that's there day by day by day? How is the depression affecting people? So we're going to look at the symptoms they're experiencing. Then, second thing I think I'd suggest in terms of determining what medication somebody needs is look at their past medication responses. It's a very simple thing to do, but it's often overlooked. Just simply ask them, what medications have you tried in the past? And it's ideal to try to categorize those past medications based on their mechanisms of action. I've seen a lot of people who have, for instance, been on 4 and 5 different serotonin antidepressants and they all fail. Well, if you fail on a couple serotonin medications, you're probably not going to be successful in the third one. So it's important that we very specifically categorize what medication trials people have had in the past, what good effects they've had, what bad effects have they had. If you have a 50% or more improvement with a certain medication, you might want to try to stick with that one and add other things to it if necessary. Third thing we'll do after looking at diagnosis, after ruling out medical problems and looking at past medication responses, very importantly, look at what family members have responded to or not responded to. So in other words, look at the treatment responses for family members. If you have a mother, father, brother, or sister who's done really well on a particular medication for similar symptoms as you are experiencing, you might want to consider that kind of medication. And that's not only for psychiatric conditions, but if you have diabetes, asthma, high cholesterol, if you have a family member who's doing really well with any medications for those conditions, and you have those conditions, you might want to consider being on that kind of medication. We sometimes will indeed look at genetic testing, but genetic testing will look at how quickly you metabolize medications and determine if you need a low dosage or high dosage. So that can be helpful, and there's certain aspects of genetic testings that will tell you which mechanism of action might work better for you. And the focus of genetic testing has been on serotonin, norepinephrine, and dopamine, and those chemicals kind of sit in the passenger seat while the driver is pushing on the brake affecting glutamate, or pushing on the brake affecting GABA, or pushing on an accelerator affecting glutamate. So anymore, we're talking more about glutamate and GABA as a means of trying to regulate depression. So when we're talking about medications affecting glutamate and GABA, they might have a faster onset of action. So as opposed to starting with something that might affect serotonin, norepinephrine, and dopamine, especially if you failed on those kind of medications, we might think about something like Spravato, which is a nasal spray that can be used by itself now in a supervised setting. We're talking about now Auvelity, which can be used day by day. That's affecting glutamate. And we have a lot of other medications coming out on down the pike that will primarily affect glutamate and to a secondary degree GABA. So there's a lot of different options out there, but there's a systematic way of really going through how somebody's going to do on a medication or not, and it can be somewhat predictive. And people ask me all the time, what's the role of artificial intelligence in psychiatry? Psychiatry historically has been very intuitive. The psychiatrist just kind of talk to somebody for a while and just kind of is intuitive in terms of what might work for that person based on what they've said. I think it's important for us as psychiatrists to think as our medical colleagues will, where you systematically look at how somebody's done on various medications, what their current symptoms are, and try to put that so-called phenotype, which is a cluster of symptoms, together to figure out what medication will work versus another. And if somebody's failed, for instance, on one class of medication and had horrific side effects, you probably don't want to put them on a similar type of medication in that class. So there is a way to kind of dissect who's going to be doing well one way or another. Thanks for your call. Let's go to our next caller. Hello, Pete. Welcome to Matters of the Mind. Pete, you mentioned that you missed a dose of your medication, and you want to know, you take it twice a day, and you want to know if you should double up or wait until next time. Pete, it depends on which medication you might be taking. If you're taking it twice a day, it probably is a medication that's not lasting very long. And well, you might want to talk to your clinician about it. It's based on that medication. But if you take a medication twice a day, I'm going to give you an example here, buspirone. Buspirone is typically given twice a day. If you miss the dosage in the evening, yeah, you probably don't want to double up on it. Just wait till the next day. Shouldn't be a big issue. There's the old immediate acting venlafaxine. If you miss that second dosage, you're going to feel pretty badly within an hour or two of missing the second dosage if it's immediate release venlafaxine or Effexor. So you might want to take the dosage later on. But generally, you don't want to double up on doses, but that's always to be left to your clinician. It's best to let it go. And if you miss the dosage and you wake up at 2 in the morning and you think, oh, I think I missed my bedtime dosage for this or that, typically you don't want to take the dosage unless it's a kind of medication that you can take at that time of night. But talk it over with your clinician concerning the type of medication you're taking. But typically, we don't recommend people double up on their medication because you can get walloped with a very high blood level very quickly if you do so. Pete, thanks for your call. Let's go to our next email question. Our next email question reads, Dear Dr. Farver, what are the long-term concerns if a mental illness remains untreated? I have a teenager who has some struggles. There's a temptation to see if things run their course. Would you approach this differently if it was an adult? I'll ask the second part of that question first. Yeah, I would approach it differently as an adult because with teenagers, their brains are still growing and they tend to be they're resilient in a lot of ways because teenagers, their brains are growing so quickly that they might not be bothered by something 3 or 4 months from now that they are now, because the front part of the brain is the part of the brain that's used for judgment, impulse control, even focus for that matter, and it continues to grow until you're 24 years old. And that's why I'm always preaching to adolescents and young adults, don't use cannabis or marijuana because it actually slows the progress. And I'd certainly say, boy, don't use alcohol because your brain's still growing and alcohol just fries the memory center of the brain, especially for children, adolescents, and young adults for that matter. So until you get to be 24 years of age, you want your brain to grow to its full capacity. So you don't want to do anything that's going to hinder its ability to continue to grow and grow and grow. So with an adult, I'd suggest that if you're having what's called functional impairment and you're having difficulty getting along with people, you're having trouble at the job, you're having trouble in school, you're having trouble getting things done to the extent that you expect to be able to get things done, and you're having a hard time finding joy in your life, if you're having trouble with the pursuit of happiness and you're just not able to get things done to a reasonable degree, you bet you might want to get treatment if it's going on over 2 weeks. So as an adult, if you have a long extended period of depression or anxiety, it can be considered to be toxic to the brain. What's that mean? Well, it means your little neurons that have all these billions of little connections on, or millions of connections on them, they're shriveling up. And as the neurons are shriveling up, that will cause you to have trouble with communication from one neuron to another, giving you trouble with concentration, focus. And actually, there's a study on people over 65 years of age. If they have chronic, untreated depression, it goes on week after week after week, they are 4 to 5 times more likely to have Alzheimer's dementia. Because with Alzheimer's dementia, the part of the brain that is shriveling up is this part of the brain called the hippocampus. The hippocampus is over here on the yellow part of the brain, on the top of that yellow part. Brain's kind of shaped like a boxing glove, and it's at the top of the thumb. Hippocampus is the memory center of the brain, and it shrivels up. If you have depression, also shrivels up, especially for women if they drink heavily, they drink alcohol heavily. So that's the part of the brain you don't want to see shriveling up over the course of time. Chronic depression can do that. So chronic depression itself is toxic to the brain. Even more toxic to the brain will be psychosis, where somebody's losing touch with reality. That's highly toxic to the brain. because with psychosis, there's an excessive amount of this excitatory chemical called glutamate. It's similar to what you'd see with a seizure. If too much glutamate will give you a seizure too, but if you have excessive glutamate, you can have seizures, psychosis, and neurodegenerative conditions like Alzheimer's, dementia. So excessive glutamate is like putting too much fertilizer on your lawn. You know, you might think, well, gee, lawns tend to grow more robustly with fertilizer. They're nice and green and thick. Why shouldn't I dump a whole bunch more fertilizer on there? Well, if you do, you're going to fry your lawn. And the same will happen with your brain if you get too much glutamate. So there's always that nice balance in the brain between glutamate and GABA, glutamate being the accelerator, GABA being the brake. You want that nice balance going on there, but you don't want excessive glutamate, and that's what happens sometimes when people get depressed and anxious and they have neurodegenerative conditions. If you have excessive glutamate, it will not get cleared from the system so much. With each individual neuron, there's these other little cells called glial cells that tend to clean up the excessive glutamate. And if the glial cells are sick, they don't clean up the glutamate. So it's kind of like having a pit crew at the Indy 500. At the pit crew at the Indy 500, I think they have 9 pit members around each car when they come into the pits. Well, in our brains, there's roughly 8 to 10 glial cells around each individual neurons. If those glial cells are sick, and they're not cleaning up the glutamate so much, it'll actually fry the neurons themselves. That's the problem with long-term problems. So with an adult, long-term depression, anxiety, psychosis, mood disturbances of any type like bipolar disorder can actually be toxic to the brain. With an adolescent, going back to your original question, with an adolescent, it's a judgment call. If it's causing them problem in school, with socialization, with getting things done, and it's not clearing up as you would expect, you can always talk to your primary care clinician, the pediatrician, or whoever might be involved in that person's medical care to give a judgment call if they do need any medication treatment, if they need counseling, or what direction you might want to go. Thanks for your call. Let's go to our next caller. Hello, Jerry. Welcome to Matters of the Mind. Hello, Jerry. Hello, Jerry.
Yes. I was wondering, does lack of sleep contribute to agoraphobia? Is there a good medication for that?
Lack of sleep can contribute to a lot of problems, Jerry. Lack of sleep basically doesn't allow your coping part of the brain, the left front part of the brain that allows you to cope with different life circumstances, allows you to think through your problems. If you don't get good sleep, Jerry, it's a kind of a vicious cycle because lack of sleep will thereby give you trouble with depression and concentration difficulties and anxiety disturbances. You'd mentioned agoraphobia, where you have a hard time getting out. Agoraphobia is often preceded by panic attacks, and there might be a reason to having trouble getting out, and that sometimes will go along with social anxiety as well. So if you have any difficulty with sleep disturbances, it can cascade and cause a lot of mental health problems. That's why as psychiatrists, we will often look at sleep disturbances as being like a psychiatric vital sign. We're always asking people about their abilities to get to sleep, stay asleep, waking up too early, feeling refreshed the next day, needing to take prolonged naps the next day. These are all symptoms of impairment in sleep. And if you have impaired sleep, it's like your cell phone charger, your cell phone not getting adequate charge on it because the charger's bad. So you want to get that brain charged up at nighttime with non-REM sleep, which is a deep sleep, and REM sleep, which is a dream sleep. And that will refresh the front part of the brain, again, which is the thinking part of the brain. So if you're not thinking through clearly on your life circumstances, you can misinterpret the world around you, including a fear of getting around other people, getting out in open spaces, and having the symptoms of agoraphobia. So what medications would you use? I try to stay away from the so-called Z drugs, the Ambien, Lunesta. Popular use, they work exceptionally well for a few weeks, but often they will fade in their effects long term. I'm getting away from using a lot of those type of medications. A simple medication for getting somebody into a deep sleep and getting somebody into REM sleep normally would be a medication like gabapentin, also known as Neurontin. That's was originally used for seizures, and it got used a lot for pain. In psychiatry, we're using it a lot for sleep and anxiety disturbances because it gives you a good efficient sleep. It gives you a good recharging of the brain. So doses no more than 100, 200, 300 milligrams at bedtime is what often will be effective. Trazodone is a medication that's been around since the 1990s for depression. We do indeed use that. for the purpose of helping people sleep. It too will get you good 8 hours of sleep, give you a deep sleep one way or another. So trazodone is a medication that we'll often use doxepin, 3 to 6 milligrams at low doses. It's an old antidepressant, but at tiny little doses, it goes by the trade name Salinor, but at tiny little doses, it can be a medication that will not only decrease the release of histamine, but block of histamine. Histamine decreases, or what will allow us to sleep. So doxepin is actually decreasing the transmission of the histamine itself. So there's a lot of good medications out there. Talk to your clinician about that and look for the possibilities. Jerry, thanks for your call. Unfortunately, I'm out of time for this evening. If you have any questions concerning mental health issues that I can answer on the air, you may write me via the internet at Matters of the Mind, all one word, at WFWA.org. I'm psychiatrist Jay Fauvre, and you've been watching Matters of the Mind on PBS Fort Wayne, now on YouTube. Thanks for watching. Have a good night. Good night.
Cameron Psychiatry, providing counseling and care for those that may struggle with emotional and behavioral challenges. More information available at CameronMCH.com.